Hello, my name is Caroline Lisee, and I'm a postdoctoral research associate at the University of North Carolina at Chapel Hill. Today I'll be summarizing my paper, Differences in Gait Biomechanics Between Adolescents and Young Adults with Anterior Cruciate Ligament Reconstruction. This article can be found in the Pediatric ACL Special Issue in the Journal of Athletic Training. Aberrant gait biomechanics are prevalent in the surgical limb of individuals following ACL reconstruction. They include smaller knee flexion angle excursion through early to mid stance and smaller knee abduction moment and knee extension moment during the first 50% of stance. Aberrant gait patterns post-surgery have been linked to poor knee joint health, including post-traumatic osteoarthritis-related symptoms and development. Most of the studies to date have included young adults with little to no inclusion of adolescents, despite the fact that adolescents are the highest risk population to sustain an ACL tear and undergo reconstruction. Therefore, the purpose of this cross-sectional case control study was to compare gait biomechanics throughout stance between adolescents, who were those identified as less than 18 years old, and adults who were 6 to 12 months post-surgery, matched based on sex, time since surgery, and BMI. Gait biomechanics at habitual walking speed were assessed using 3D motion capture. Gait differences between adolescents and adults were compared across gait stance where 0% represents heel strike and 100% represents toe off. Participants were on average 7 months following surgery. Adolescents from our ACL reconstruction cohort demonstrated statistically significant slower walking speeds that exceeded the minimal detectable change compared to adults. Overall, gait patterns differ between adolescents and young adults post-surgery, indicating that age may affect gait biomechanics in cohorts that include both adolescents and young adults. Based on previous literature in uninjured individuals, peak knee joint moments are smaller in adolescents compared to adults, so these results were expected. Unexpectedly, adolescents post-ACL reconstructed surgery demonstrated greater knee flexion compared to adults, regardless of walking speed, and therefore may be aberrant. In uninjured individuals, gait speed increases throughout adolescence, remains consistent through young to mid-adulthood, and then declines in elderly age. Therefore, slower walking speed may be expected between groups. However, it appears that walking speed is slower in adolescents and adults post-surgery compared to uninjured cohorts from previous literature. Slower gait speed is associated with worse knee joint health, so we wonder, do the same associations exist in adolescents, or are they resilient to the effects of slow gait speed? We speculate that walking at habitual speeds with greater peak knee flexion angles during early stance and less knee range of motion may shift tibiofemoral contact locations more posteriorly, concentrating tibiofemoral contact forces in the posterior area of the cartilage and may negatively affect knee joint health. Targeting peak knee flexion range of motion from early to mid-stance after surgery is a primary goal of gait retraining interventions to improve knee joint health and may be relevant to address in adolescents if they walk at uncharacteristically slow speeds. Future studies should focus on determining if aberrant gait biomechanics have the same effect on long-term health in adolescents in comparison to adults after surgery, and whether changing gait biomechanics in adolescent patients may influence disease modification. Overall, adolescents walk at slower gait speeds and with greater knee flexion compared to adults 6 to 12 months after surgery. Healthcare providers and research should consider the effects of age on gait biomechanics when implementing age-specific rehabilitation interventions post-ACL reconstruction.